A very warm welcome to everyone to the session on webinar series titled Community Health Workers, Frontiers of Thinking and Evidence, hosted by Oxford Policy Management and Women in Global Health India. Before we begin, I would just like to go through some ground rules. We would be recording this session in case any of the participants who would not like to be recorded, please let us know and we will take a note of it. I request all the participants to share their thoughts and reflections relevant to the discussion in the chat box. Kindly post your questions in the Q&A section, which has the option of upvoting or commenting on the other questions as well. The questions will be taken up during the dedicated Q&A section by our moderator. Also, while sharing your reflections from the session on social media, we would request to tag us at OPM Global and at WGHI India in your post. Well, the series aims to share evidence on CHWs and CHW programs to identify gap in evidence and potential way forward. In this series of webinars, we've already had 3 sessions. We have made a conscious effort to engage in a collective dialogue with multiple stakeholders across CHWs, health systems practitioners, researchers, program managers, and civil society members to understand how different perspectives stand on various issues associated with community health workers and the community health worker program itself. The first session in the series was held in November. We began with asking the question on how can CHWs feel empowered? And the discussion led us to understand that CHWs are actually empowered and intrinsically motivated women. They navigate through the constraints of the health systems. Thus, what they need is an enabling ecosystem. This session was also fed into our second session, where we discussed the functioning and how the CHWs actually engage with the community at the interface while delivering primary healthcare services. While CHWs are empowered women, they're also a part of the community that they work in. Hence, they are also vulnerable owing to their social location and the complexities of gender. Thus, in addition to providing a CHW centered policy, there is also a need to adopt a rights based approach and build strong accountability mechanisms where the formal system is both accountable and responsive to the people it engages in the delivery of services. Our third session, we discuss how we leverage digital interventions as the enabler to support CHWs in their work. Our discussion during this session culminated to understand that when CHWs are the primary end users of many digital tools, it is critical to identify their needs and requirements, the availability of digital infrastructure in low resource settings, relevance of the digital tool to CHW's work, reporting burden, differential training based on digital literacy. These are some of the important considerations that can potentially enable or deter the uptake of digital tools. Today, we have a fourth session, which is where we would be discussing the role of community health workers in building resilient health systems. We intend to discuss and deliberate on the learnings from the COVID-19. We hope to tackle the imperatives of building a resilient health systems, what it means in the context of community health workers. Uh, it's my privilege to introduce our keynote speakers and the panelists for today. We have Professor Lucy Gilson from University of Cape Town and the London School of Hygiene and Tropical Medicine as the keynote speaker, who is known for her seminal work in the domain of health policy and systems research, health leadership, and health systems also. Professor Lucy's research broadly focuses on how to strengthen health systems to offer better public value with particular concerns for health equity. She has a keen interest in understanding health systems actors' decision making. Her work also considers how trust and power relations shape health systems dynamics and complexity. Amongst our panelists, we have Sarojini Nadimapalli, who is the co-founder of Sama Resource Group for Women in Health. She has been working in the domain of public health and women's health issues over past 2 decades. She's the coordinator of the Gender Justice Circle of People's Health Movement Global. She has led several research studies and has been involved in policy advocacy on health systems, medical and reproductive technologies, access to medicine, and ethics in clinical research. Currently, she is an expert on she's on the expert committee constituted by the National Human Rights Commission to look into the impact of COVID and develop advisories to the government. Our next speaker is Rajiv Sadanandan, who is the CEO of the Health Systems Transformation Platform, which is a think tank on health policy and systems. In addition to holding many other positions in state and central government, Rajiv sir has worked as Health Secretary of the Kerala State, CEO of the Rashtriya Swasthya Bima Yojana, India's national social health program. He has also been a member in the technical committee set up by UNAIDS and WHO. He's also currently one of the commissioners on the Lancet Global Health Commissioner on financing primary healthcare. During COVID, he has been working with the state government of Kerala for effective management of the pandemic response. Our third speaker is Avni Kapoor, who is a director with Accountability Initiative. The focus of her work has been in building evidence for policy advocacy and strengthening transparency and accountability in public financial management for service delivery. She has also been anchoring publications on the annual budget brief series and implementation of fund tracking surveys. Recently, she has led a research study on experience of frontline health workers, health and nutrition workers during COVID-19 in Rajasthan and Himachal Pradesh. As the moderator for today's session, we are glad to have Dr. Sudha Ramani, who is a fellow colleague and health systems researcher at OPM. Dr. Sudha is also a co-lead on the HPSR domain at OPM. She has worked on examining the macro and the micro context of primary healthcare in India and how it affects primary healthcare service delivery. Her most recent work looks into learnings from COVID-19 for building resilient systems. Now, without further ado, I now hand over the mic to Sudha for beginning the session. Welcome everyone once again. Thank you.
A very warm welcome to everybody who's joined us today at this session, and thanks Arpana for the lovely introduction. It's with great pleasure today that I start off the discussion with Dr. Lucy Gilson, who's giving the keynote address for this particular session on resilience. So Lucy is a wonderful woman in global health, as well as one of my favorite mentors. So Lucy, we all know that nowadays everybody is talking about building resilience in health systems, and particularly after Ebola and COVID-19, resilience seems to have become the next buzzword in health systems. So we wanted to ask you, drawing from your own work, what does this term mean to you? What does resilience mean to you?
Thanks, Sudha, and it's great to be with you all. So I think it's important to start by saying that resilience is a term widely used outside the health sector. So as a health sector group today, we've got a lot to learn from those wider experiences. But the term, it did come to the fore in the health system with the Ebola outbreak, and of course is now being widely discussed. So it is relevant to these disease outbreaks, but it's also used in relation to a wider range of issues. For example, the 2018 High-Level Commission on Quality of Care included concern for resilience in their work. And in the work that I've done, we've been thinking about resilience in relation to health system responses to challenges such as large-scale organizational change, forms of decentralization, for example, as well as things like very frequent changes in policy direction and the chronic shocks of things like drug shortages, staff absenteeism. So for me, resilience isn't just about how to respond to disease shocks. It's a characteristic of every health system, and it has relevance to its everyday function. It really focuses on how the beast that is the health system, which is complex and adaptive, how that beast responds to all of the everyday stresses, not just the acute shocks, and how, if you like, the system manages them. So it's a capacity or ability, not an outcome. And it's embedded in processes that occur over time. So it doesn't come from a one-off action.
Thanks, Lucy, for that. So for expanding on what resilience sort of means, and it's more about, say, not just about the response to the pandemic, but more about how the system responds and copes with everyday stresses and challenges, and also changing policies. I just wanted to clarify at this point, when you talk of resilience, do you look at it as something particular to individuals in the health system, or are we talking about something more abstract, like system level resilience?
So it's really important to remember that health systems are living human systems. So people are central to what they are and how they operate. And so people are also important to resilience. But individual level responses and individual level resilience is not, for me, the same as system level resilience, which is a more collective notion, if you like, and requires collective action by the health system. So people are important, but so too are processes of leadership and routines of decision making, and the way in which people come together to make decisions and what informs those decisions when they make them. So that's why on the slide that's showing on the screen at present, in our notion of everyday resilience, we've emphasized in the yellow blocks leadership routines and organizational processes, and the blue blocks talks to the sorts of strategies that are linked to resilience. The green blocks are the collective capacities that underpin those strategies. And we're also stressing that resilience emerges over time. So it's not a once-off event. And all of that is nested in a broader context. So it's a combination of people and collective we have to think about.
Could you just elaborate a little bit on the different strategies that you've spoken about? I know we talk about absorption and adaptation and transformation. So perhaps you could elaborate on them from this slide for our audience.
Sure. So absorption is the process of coping with stress and shock without changing the way the system currently functions. Whereas adaptation entails some changes to the system to manage stress. And transformative strategies represent completely new ways of working that not only manage the current crisis, but actually strengthen the system to manage change better in the future. So they are different types of strategies that are implemented in response to stress. Back to you.
So when we talk about, say, absorption and adaptation and transformation, do you look at these as a progression over time, or do absorptive strategies lead to adaptation and then to transformation, or how do you see them as linking with each other in the entire system?
So our empirical work has shown that these strategies don't unfold as a linear process from absorption through adaptation to transformation. They might all be applied at the same time, but to different stresses, or different agents or actors in the system might use different strategies to respond to stress. The only thing I'd say is that transformative strategies, they are sort of looking to the future and supporting more fundamental long-term change than the others. And I also want to note that absorptive strategies are often based on individuals. Individuals are important to those strategies as they tackle the challenges as they find them and they keep the system working. But individual level resilience and also absorption isn't system level resilience. So while individuals do protect the system and maintain operations, they can't do so forever, and we shouldn't expect them to. So we need to think about adaptive and transformative strategies as really changing the system better to manage stress.
Yeah, just taking from your point there on individual level adaptation, something that we have come across in our own work with community health workers or even other people who are working in the front line is that during the pandemic, during COVID-19, they've really tried hard to cope with the sort of increasing needs of the pandemic every day. And they have been very innovative and adaptive at times. They have been they make their own masks, when they have not been provided with masks, or they find out information through WhatsApp and other groups when there is no formal training given to them. So they've had this sort of agency to go and look for all these things. But over time, we also found that they have been stressed and overburdened with the kind of increased workload that they have been having. So can I call this absorption on their part, or could I say that they're absorbing very well, or can I call these kind of systems resilient? That was one question that I wanted to put forward.
Thanks, Sudha. So I really do think that individuals coping with stress isn't what resilience is. And in fact, in terms of the theory, and as represented on the slide, we might call individuals coping with stress as something that generates maladaptive emergence, which is a concept from complex systems theory. But it's the sort of response to stress that actually is undesirable, generates undesirable outcomes. So at an individual level, as you said, in COVID, many people have been coping with COVID and in responding to COVID, but at a cost to themselves. And we've seen how health workers are managing now distress, despair, mental health challenges as they have been absorbing the stress that COVID represents. So I'd see that as maladaptive emergence. And another example of maladaptive emergence is when a system changes, perhaps apparently improving, for example, tackling drug stockouts. Now, maybe the system is improving at the average level, but in fact, there remain and perhaps worsening inequities in stockouts between, for example, urban and rural areas. So the sort of inequities that might result from being resilient, or the negative consequence of resilience, are really important to think about and have led people to criticize the notion of resilience for failing to engage with issues of equity and power, and for ignoring lived experiences of individuals in systems.
I thought those are fantastic points. I just want to also request the other attendees and anybody from the audience, if you have questions, please post them, and just after a couple of questions, we will take some of that. Just stemming from what you're saying, just taking off from there. So what would you suggest? So some things that I heard you say is that resilience is something that we build every day, and also we shouldn't put the stress on the individuals, but on the system. But how do we go about building such resilient systems? And what would be your thoughts on that?
Thanks. So that's where the green blocks on the slide, what we call the resilience capacities, are important. So we need to find ways to nurture and develop those capacities. The contextual capacities are relationships within, across, outside a system. The cognitive capacities are the way we do and think about problem solving in many senses. And the behavioral capacities are the practices that we adopt as we problem solve and reach for solutions. And within those capacities, the building of relationships is important, the establishing processes and spaces of what is called collective sense making, where people come together in teams to understand problems and together think about how to address those problems. Being positive around problems, thinking you can make a difference, is also important. And sometimes tackling what are called dysfunctional behaviors, organizational cultures perhaps that lead to that restrain change, that's important. Now, in the work that we've done in Cape Town with colleagues in the health system here, we found, for example, that the simple act of changing the way routine meetings are organized and managed allowed frontline facility managers, primary healthcare facility managers, to come together, to share experiences with each other, to collectively problem solve, to together take responsibility for implementing the actions they'd identified as necessary. And that led to sort of gains in service delivery. So even small changes in the routine processes, the way things get done, have longer term impacts. We've also done work and pointed to the importance of strengthening leadership within health systems, not heroic leaders, individual leaders, but teams of leaders who can work together to bring about change to tackle problems. And all of the things that we've spoken about are about nurturing what I've called elsewhere the software of health systems, the values, norms, belief, usual ways of doing business, communication, the way we see and act in situations. That software supports and enables collective responses. Hardware is important, money is always important, but I would argue it's not enough by itself. And even in COVID, whilst we've seen that data is important in driving responses to COVID, how you make meaning of the data, which is a software issue, is also critical.
Thank you. I thought that was fantastic, and gives an opening into software and other things that we are talking about. There was one question from the audience, which is asking where the whole concept of everyday health system resilience is coming from, or if there's a reference for where the framework comes from. So I thought I'll ask you that.
Sure. So we've developed the framework based on organizational and other resilience theory, and I will pop in the chat box when I finish talking the reference to the work that we've done, which presents that framework.
Thanks so much, Lucy. I think there are 3 or 4 questions now from the audience, and one thing they're all about the sense that I'm making from them is they're all about how do we go about moving from individual level absorption to say more long-term resilience building in the health system when people are I think the sense of urgency around COVID is leaving, and initially there was fear and this thing which could have provided a window of opportunity, but it might be waning now. Is it possible to accelerate this sort of process from from absorption to transformation? These were a few questions that people are asking.
So, I mean, I think something like a big shock, as COVID has been, clearly is an impetus to trying to do things differently. And I think in the everyday responses in this crisis moment, there have been experiences where people have begun to do things differently. In the work that I did before, it wasn't about responding to a huge shock. It was about encouraging people working within the system to do things differently in their everyday routines, and working with the idea of what I've called small wins, where you just make a small change to the way things happen, but it begins to encourage people to work differently as teams. And I think there's wider evidence to show that even in response to smaller shocks, it's possible to do things different. So I just wanted to raise the issue of power, if I might, because I think it's really important not to forget power. And I hadn't mentioned the word as yet. And I think power dynamics are really critical. And we do need to think about how to manage power in thinking about resilience. And I think these resilience capacities give us the space to think about power in the sense of who we draw into the conversation, that we ensure community health workers, community members are part of the conversation about what challenges are and how to respond them. That will be one way of addressing power and rebalancing power dynamics. And I think that rebalancing power dynamics is important for resilience.
I think there are a lot of questions for you, Lucy, but thank you for bringing up power. And it becomes especially important in our context because our community health workers are sort of the lowest rung in the whole power hierarchy which exists in health system. And so power dynamics become a very important part of software in working with it. So there is another question, and probably this is the last one because the other, I think we have like 3 minutes left, 4 minutes left. So something about what is it, you know, if we have to take solutions from one context to another context, you know, especially I want the culture to in another context to be transformative. You know, are these software solutions scalable is one question, because you were talking about the smaller changes, and you know, or you know, how do we sort of evaluate and transfer good culture from one place to another is one question. And I think the second question that we've had is, you know, what is the difference between resilience and health system strengthening? And I'll stop there. Thanks so much.
Thank you. Let me take the second question first, the difference between resilience and health system strengthening. So I would argue that much of the discussion and many of the approaches to health system strengthening, especially when implemented by external agents, be that central government or state government or external agents, that many of the health system strengthening strategies focus primarily on hardware, and donors in particular have very short-term perspectives. Whereas resilience requires a longer term sense, and it is about working with the software, and if you like, about bringing change from within the system rather than imposing change from outside the system. So the question then is that sort of change scalable? Well, I think it's probably scalable in a different way to the way the term is normally used. I think it's not about taking experience from one site and then rapidly implementing it everywhere else. I think it's more about nurturing internal actors to do things differently. And I do believe that within organizations, within systems, where you start changing just the normal way things happen, it has transformative effects, or can have transformative effects that scale in ways you cannot imagine. So I think it's not a linear scalability. It's unpredictable. It can be like a burst of fire that you can't control, and sometimes it's a damp squib. So we have to live with the complexity of the system, and that impacts nature's scalability. But because you start somewhere small does not mean you can't have transformative effect. But you cannot replicate in a linear way. It has to be about nurturing and setting fires burning so that people continue to do things differently in the future. I hope that helps.
That was great, Lucy. I thank you so much. I like the idea of setting fire and bringing about transformation. But you start off small and not expect a linear transformation, but something that you nurture over time and hope that it gives results, and also be aware that there might be some potholes on the way. So thank you so much for that. Just any last, just one take-home message on community health workers and resilience in particular, and then you can just have a look at the chat box if you have anything more to say. Thank you so much.
So, I mean, I think community health workers are so important in health systems, and so have been so overlooked, if you like, but also have been treated in quite a mechanical way. We can just replicate health workers, they'll just do what we want them to do, and that's obviously a problem. So I think it is really essential that we think about the role of health workers within health systems, and that they become members of the teams within which we are seeking to nurture resilience, and through which we are seeking to nurture system resilience. And their power of frontline engagement, frontline knowledge, frontline experience is so important to the resilience of the whole system. Thanks so much, Sudha.
Thanks so much, Lucy. I think those are very meaningful words to end with, that community health workers need to be nurtured. Their power to speak, their power to act must be enabled and supported. Thank you very much for joining us today. I know there's a lot more that we can talk, but considering time, I think we've had a lot of great conceptual learnings from you on resilience and different things to think about on how we can go about building it in the front lines. So maybe thank you again for joining us, Lucy. And just moving on now from conceptual ideas in resilience to some more applied sort of examples from India. And here I would like to welcome again our other panelists who have their own rich and diverse experiences to share with us. So a very warm welcome here to Sarojini, to Rajiv, and to Avni. Thank you so much for joining us today. What we thought we would do today is we have two sort of semi-fictionalized vignettes here, and we are sharing this, and we thought that we, along with the panelists, we could have a discussion around these. But also I request the audience to engage with these vignettes, post your comments on what you think about them as we move along also. So I just quickly read out the first vignette. It is on initial absorptive strategies in the front line. So this vignette stems from what Lucy was saying about individuals being very central to the absorptive strategies in health systems, and they are the ones who tackle the challenges as they face them, and keep the system working. So just reading through this before we start off. In March, we all heard about Corona. Everyone was talking about it. At that time, there was no training. Later trainings happened, but we read about it on WhatsApp and the newspaper and tried to get information. At that time, there was a lot of fear in the community. I told people that they should not panic, but stay home, but I was myself in panic. At first, everything was closed and I had no work. I was worried about my incentives. What if I had to stay home and no money comes? Then we got instructions to do surveys, screening. We could do this since we knew the houses well. We know people and where they stay and where they hide too. We had phone numbers of pregnant women. We were the only ones working while everyone was safe at home. I did not feel secure, but I went since I had to go. So this is a vignette which is fictionalized from some of our own work with community health workers. So I thought we'll have a round of questions to the panelists. This time, I would also request the panelists to be on video if they are comfortable and we could talk to them. So my first question is to Sarojini. This vignette sort of highlights some of the initial ways in which CHWs absorb stress. So maybe we thought from your own context, you could talk about some of the absorptive strategies that you observed and what, with your own rich experience, what you found about community health workers that you interacted with and how they absorb the additional stresses. Over to you, Sarojini. Thanks so much.
Thank you so much, Sudha, and to the organizers. And it's, the way Lucy has presented, it set the tone for our discussion. But I have a point to make, just because I thought let the participants pose the questions than coming from the panelists. It's not a question, in fact, it is just an addition, maybe, the way I was looking at resilience. I thought, let me just flag that and then come back to the point which you have asked me. I think in the context of community health workers, so, resilience of community health workers must be recognized, appreciated, and acknowledged, as it also, contributes significantly to the resilience of the system as a whole. But we must also recognize that this resilience is a political resilience. The proximity, for example, Asha's for instance, in our own country, to communities, their role as primary caregivers, including their gender and different identities, which caste, which religion, as persons located within the communities, and in times of crisis, makes resilience a point of political contestations too. What Lucy said, it is true. Individuals are, in effect, made responsible for dealing with the collective challenges, and that should be dealt with by collective structures such as the state. So an accountable system creates unaccountable service providers. Likewise, agencies or lack of it is somewhere building resilience of the system. So community health workers' resilience should be seen not as an individual resilience or that of a collective, because resilience as a process, often the way in which societal and political context is minimized in the what we have read in the resilience theory is usually individualized, and the way it gels with the politics of neoliberalization. So there are many theories which are emerging, the socio-ecology of resilience, and then they are talking about move beyond this, and build the interventions which are focusing not on the individual, but on the entire social and political environment. I just wanted to, comment on that. I think it's already come in her, very sharp presentation. I'm very glad. Coming to the question which you have asked me, I think it's quite, it's an important question, but for me, when I looked at the, when you send the questions about the absorption strategies, I was just contemplating, there are many ways I can answer to that. First, I thought, let me, put upfront on this absorption, so-called, with the system, because ASHAs are working since last 12 to 15 years. Then they should be absorbed in the system as a regular staff. I'm looking at the absorption technically here. And they should receive salary based on the minimum wages policy declared by the government. And also, recently under NHM, we have seen for the contractual workers, the government of India has declared the additional increment in the last October 2020, where they are getting rupees 15,500 per month. But they have not included ASHAs and block facilitators in the category of contractual staff of NHM. So the state has done agreement with block facilitators as contractual worker for 11 months, but they are receiving very less. And ASHAs are nowhere in that scene. So there is injustice is being faced by the ASHAs and also to some extent block facilitators. So the major systemic issues of contractual appointment of all frontline health workers on temporary basis, where, for example, recently I was in Odisha, they have appointed the frontline health workers on contractual basis with the maximum 3 to 6 to 9 months appointment with no social security, medical insurance, followed by descending them without any future commitment. These are the issues. But again, what is the absorption and then where do they go for? There is absolutely no grievance redressal, which is a major issue. The state governments should establish a round-the-clock health grievance redressal system, from at various levels. I think that is something very, very important. Having said that, on a positive note, when we are talking about the support spaces, like for example, I have seen in Odisha and also in Chhattisgarh, the ASHA union is a strong unit, that played an important role. So in the time of crisis, the ASHAs did not feel that they were, sometimes, not alone, but there are these fellow ASHAs who are undergoing again in the same community, which was coming together and to face the challenges. And that actually, the union helped them through several events of crisis. In Chhattisgarh, I have seen that Mahila Arogya Samitis, which are the women collectives, they played a key role in to some extent, supporting, holding hands of the community health workers, even in the context of ration distribution and other, social security, providing that kind of, support. So I think that there should be a strong network within the community also, but at the same time, the role of the state in the context
Absolutely.
of grievance redressal is very important. Yeah.
Thank you so much. I think that's a great point, and completely agree with you on the sort of the structural aspects of resilience that you brought out. That how do we absorb frontline workers into the health system also matters, and the kind of position that we give them is also important to creating a resilient health system. So thank you so much for your emphasis on that. Rajiv, I thought we will ask you next. Would you have the same thoughts as Sarojini, and anything from our vignette that sort of differs from your own experience in Kerala? I know that Kerala is known for its fantastic response to the pandemic, so maybe we thought you could give us some insights from your own experience. Was it similar to what we heard or something different? Over to you, Rajiv. Rajiv, are you able to unmute? Maybe.
Sorry to interrupt, Sudha. Maybe I think Rajiv got disconnected, so we move ahead and come back when he rejoins.
Sorry, Avni, maybe you could tell us. I know you've done Avni and group have released a fantastic study from Himachal and from Rajasthan on what are some of the experiences of community health workers during COVID, and maybe from your own research experience, and that to two states. So maybe you could contrast both of them and tell us something about what your experience was relating to the absorptive strategies of the front line. Thanks. Over to you, Avni.
Thanks, Sudha. I think what's been fantastic about this conversation is that we're talking both about people but also systems, and often conversations get either limited to just systems and not people, or vice versa. So just to give you a small background for everyone, we did a study from October to January in two states, Rajasthan and Himachal Pradesh, and they were chosen partly for their differences in their governance structures. The main idea came from prior work we've done, and we've been doing this repeatedly since March, of documenting the experiences of people who form the community health workers and frontline workers. So we've been going repeatedly since lockdown and then post-lockdown, and not as a research study initially, much more as a documentation exercise of just hearing what they are going through in their own words. Eventually, we decided that I think we need to study this systematically. And so we took forward and used the fantastic work done by OPM colleagues. I see Tom in the attendees. So Tom, Shuchi, and Aparna, thank you all so much for the MMO framework that looked at the community health workers. And I think Lucy's framework is also fantastic. And I'm looking forward to all the exciting work that's going to come with it. So just going to the study itself, I think what we found was very similar to what you said, is that this feeling of going beyond and above your original duty. So you had to do additional tasks in terms of testing for symptoms, counseling on social distancing and safety norms. What's also interesting is that existing work continued. Albeit it is lower scale, but it still continued. So whether it was antenatal care, take-home rations, distribution of IFA, all of these activities continued simultaneously along with a lot of their new COVID-related duties. And what's been interesting and amazing in terms of the absorption, and thank you, Lucy, for this term, because it was in some ways absorbing a pandemic that none of us were at all equipped to do. But what we kept hearing was this feeling of sense of duty. We heard things like, my country needs me right now. This helps me cope with the stress and workload. We heard things like, we'll do our work without hesitation, even though it is a lot, because I know that my work and my profession is important to this country. I think that's what's been fascinating as well in this narrative, is that the frontline workers, which are often very much neglected, suddenly became this idea of corona warriors. And I think at least initially, that definitely helped in terms of coping with stress. And how innovative and creative they were. So we've heard stories of people actually reading the newspaper in their spare time, saying we want to know enough about COVID-19 so that we can answer questions that come to us. Because, you know, the things happen, but possibly not at the same scale or the same levels. Some of them said that they ended up talking to older frontline workers, so those who had retired as well, just to get advice on how do you manage work. And we've heard other stories of where they helped community workers get their food grains. So I think, again, what has been fascinating is that in a very short period of time, we adapted to get the state into people's homes. So when earlier you had to go to the Anganwadi center to get your grains, suddenly we had a situation where we're trying to give the rations, etc., to people's homes. So all of these exercises that we saw was definitely very much in that absorption zone. And all of this, while many of them were facing their own challenges. So I think about 35% of frontline workers said that they're just not able to visit their friends, their families. Many of them had to maintain distances from their own children, travel very long distances. And that's, I think, where big differences between Himachal and Rajasthan, obviously, a lot more distance. There was also unemployment within the family. So it's something that we often forget. We talk about unemployment levels rising across the country. And while the frontline workers themselves were employed, but as Sarojini also mentioned, the honorarium is extremely low, but there were members within their family who lost income. So you're also doing it partly because of compulsion as well, which was the other side of absorption. So while it was partly a sense of duty, and I think a majority did it for that, but there was also this feeling that I do need to go out and I do need to, in some ways, risk my life because I may be the only breadwinner in the family right now as well. So I'll pause here and look forward to your next round of questions.
Thanks, Avni. That was great. I think it gives us a picture of how things were, what were the issues that the community health workers faced in as individuals in Himachal and Rajasthan. And thank you so much for giving us a peek into that. Rajiv, if you're back, maybe I could ask you the same question.
I'm back. So I'm sorry, I lost net. So I'm on my phone, so I'm not using my video. You put up with me. Yeah. So do you mind repeating the question, Sudha? What you asked me?
We were talking, so Sarojini was talking about structural issues which hampered CHWs, and Avni, I think, gave us an individual perspective on, absorptive strategies used by CHWs. So we thought if you could talk from your own experience in Kerala, we know that Kerala had a great response to the pandemic. So maybe you could give us some insights, into whether your experiences were similar to what everybody was the other panelists were talking about, or Kerala has a very different context. If you could tell us a little bit about that. Thank you so much.
Okay. Once again, apologies if my net remains patchy. So can you do me a favor? Can you put Lucy's slide back on? Is it possible? I think I'll find it a lot easier to explain. Is it possible? You can't. Okay,
yes,
fine.
Yes. Just give us 2 minutes.
No problem. So what I'm driving at is that our focus on individuals, which Lucy has very eloquently called a maladaptive, response, is something that we need to keep in mind. Any component of the health system that responds to a shock, the response will have ripples across the system and will also use capacities within the system. For example, if you look at Lucy's slide, she talks about absorptive, adaptive, and transformative. At this point, I'll keep transformative aside because that has a lot of necessary conditions to be satisfied for that. So let's look at the absorptive and adaptive. Now, as absorptive is what will happen. You're kind of it's part of your routine work, and you're kind of used to it. Adaptive is a slightly extraordinary situation, but you can still handle it. Now, the necessary condition for doing this is having the inbuilt capacity to make those changes. And as I have said before in one of my earlier writings on this topic, you cannot build a health system to handle an emergency during an emergency. The capacity had to be there before. So the advantage that Kerala had was that Kerala had adapted. Most of the Indian states use the central government guidelines on working with ASHA to govern the relationship. That wouldn't work in Kerala, because if you're talking about a state that has got 100% institutional delivery, how do you incentivize an ASHA worker for taking people for institutional delivery? Whereas, on the other hand, you have 30% prevalence of hypertension and 20% prevalence of diabetes. So the experience Kerala's health system had was in adapting the system or adapting the institution of ASHA workers to suit their needs. Now, that experience came in handy during the COVID pandemic, because they were not tied to the original prescription of their work. Their work had already been changed once, and changing another change wasn't too difficult. And because Kerala had this experience of, and again, the evidence for this is that all the health systems that had to adapt to a shock in the past, like the SARS epidemic in Southeast Asian countries, did better, because the capacity for adaptation was already there. Same thing with ASHA workers. The system knew how to track, trace, and quarantine, and passing that knowledge onto the ANMs knew it. So ASHA's training it wasn't a hard job, and ASHA's brought in a great understanding of the social milieu in which people were working and in which quarantining need to happen. And there were some complaints. I mean, this Vinlet talks about incentives not being paid. That didn't happen because that was also factored in, because you knew that you couldn't meet your target. So an additional incentive was provided for working for COVID duty. But what came out was that normally the ASHA worker works with a certain socioeconomic class. Unfortunately, for everybody, COVID does no respect of socioeconomic class. Everybody got affected. So just because somebody is rich, there is no way that he or she can be exempted from quarantine. And it's the ASHA worker who was in charge of getting the information, practically enforcing it. So that led to a very interesting power dynamics and play out, and it will lead to problems. But the fact that she and the ANMs and the multipurpose male workers were the people enforcing it, and the fact that it was recognized important by the state, I think is what helped shape Kerala's response on the field. I hope that is. Yeah, thank you.
Thank you so much. That was very interesting to hear. So particularly, I think it ties in with what our other two panelists said also, that, and I think you put it really well, that you can't build a health system that is resilient to handle emergencies right when the pandemic is going on. Like, you can't build a boat during a flood, but you have to do some of the things before. Thank you so much for pointing that out. And it was also interesting to hear about the changed power dynamics. So maybe just to go into a little bit more details on this, we could go on to our second vignette. Arpana, maybe you could move to that quickly as I'm talking. Yeah. Yeah. So our second vignette is on challenges, burnout, and I think we spoke a lot about this, but that our frontline workers are very persistent and brave, but at what cost is something that we all have to consider. So I'll just quickly read this out and then we'll move forward. At first, there was less work because no immunizations were happening, and I was doing only corona work. But now we've been asked to begin all other work too. And other immunization has also started, and everyone wants data from us. It is not just the amount of work. It is like people don't always listen. Some people don't want to wear masks, even though we keep telling them. Some listen, some don't, some even shout. We are at risk of infection, and they think we might cause corona to them. The other day, some men were playing cricket, drunk too. They did not listen to us. They do not fear the disease and do not listen. I spend all day in the field, and then I come home to make dinner. I sometimes sit and make masks after 11 p.m. That too, sometimes there's no power and it becomes dark. I'm getting tired of this routine. I also heard of strikes and people refusing to work. It is natural. One can't keep working like this. So this is one of the vignettes that we had, and we thought that we could probably start with Avni at this time, and maybe Avni from, I know you spoke about some of your experiences, but stemming from this particular vignette, could you tell us a little more about probably the challenges or the burnout and what the community health workers faced at this point in time as the pandemic progressed? Thank you so much. Over to you.
Thanks, Sudha. No, I think your vignette covers it, and we found very similar things. I think I mentioned in the last time that what was interesting was that work continued, even the existing work, though at a lower scale. But what we found is that more than half of the workers reported that responsibilities had increased, which meant, if you were to put it and quantify it in some ways, it meant additional 2-3 hours of work per day. So we've also heard instances where you start your day really in the morning, you're spending a lot of time doing your existing work, and then a lot of the surveillance, etc., happens in the evening, because people that's when you can make sure that people are at home. So especially if you're talking about maintaining social distance, distribution of masks and things like that, all of that happens post 7 in some cases. We also found, as we can imagine, and we heard a lot of this even in the news, is that while many of them received some form of either masks or sanitizers or gloves, a large number of them were making it on their own. And in our surveys, we found that as many as 83% reported that despite receiving it, they had to buy or use their own resources as well. And this comes from the fact that it's not a one-time provision, right? Like there's this COVID fatigue that we're all facing, but it means that we have to regularly keep providing supplies to the front line, and often that was lacking. In terms of other challenges, I think again, in terms of motivations, and we were looking at both financial incentives and non-financial incentives as well. What was interesting there was that you found in Himachal Pradesh, a lot more people reported receiving money, and the amount of money was also much, not much, but was almost double the amount of money that was received in Rajasthan. So you have like a 96% reported receiving versus a 74%. But again, is that enough? And that's a question that I think even pre-pandemic, there's been a lot of work around the fact that we're relying on them a lot to do almost everything, and every new scheme that gets launched puts additional burden on them, but we're not really valuing them as in terms of the contribution that they do. I think other challenges that included that the concept of supportive supervision, I think, is an important one, and I hope we do talk about it when we're thinking about long-term ways of actually making the system more resilient. So what was promising was that many of them said that they did get their support, but when they didn't get it, I think this feeling of face-to-face contact and meeting people, because while technology can definitely be an enabler, I think we've all found this in terms of even the amount of digital time that we all spend, it also makes you feel alone in some ways. So I think this additional pressure of kind of having to handle things on their own was another big challenge. Another challenge I think that came up, the two others that I'll quickly speak about, I think one was the community challenge, and this was sad, and we've seen some really shocking videos that did the rounds as well. So as many as 70% of people said that they faced some form of community challenges, and this ranged from something like lack of compliance to lack of trust, but also to people not wanting them to come close to them. So we've had interviews in the past where they're called Corona Didi because there's a fear of being infected even when they are going to do their own duties. And in fact, some places, luckily a small number, but still 5% even reported violence from the community. And all of this while, as I started off saying, that there's even your own challenge of managing your own household during this entire time, because we often forget that they have to manage their own household duties, and so in some ways it becomes a triple workload, not because you have to do COVID work, your original work, and then of course the often invisible and unrecognized household work as well. So these were some of the challenges that we also came across.
Thanks, Avni. That was fantastic. I think what you're saying so well ties up with our own vignette as well. You know, that community health workers, they were being very brave and persistent. They were also getting tired at some point because there was a lot of burden on them. So Sarojini, again, I think this stems from Lucy's point again, that, you know, individual level resilience and the way they adapted and they coped to the community level people adapted and coped with the pandemic. It did protect our system to some extent, but should we expect them to do so? You know, have we put too much pressure on them? Did we expect them to bear too much? Maybe from your experience, Sarojini, you can add something there. Thanks. Over to you.
Yeah, a couple of points which I think Avni has covered quite a bit, but I just want to add from our own experiences, which are in fact till day before yesterday sitting in Bhubaneswar and listening to some of the concerns when we pose this question of how do we, in this context, even say the word overburden, you know. Absolutely, you know, they were overburdened and there were countless examples. And since last 15 years, all the ASHA workers are a part of the public health system, and they have given almost 78 tasks on paper. More than 20 are being given by issuing many GRs and circulation from various states. And they have been asked to perform various unwritten tasks on daily basis also. And this pandemic is no exception. But yet, yeah, their workload has been increased, and there are different ways of, I cannot say violations, but the way they have been perceived, or they have been targeted on in certain ways, which is also, we cannot totally undermine in the COVID context. Like in one of our Jensen Wise, like the ASHA worker from Haryana, then she was beaten up by the police during the lockdown. And she was supposed to do I'm sure that video was all over, and then this has come up to the NHRC when I'm on the committee. And that is not just in the Haryana case, but there were many, many which happened. And the second is about, you know, they were asked to sit at front help desk at district hospital, gatekeeping the village boundaries, of course, you know, distributing the ration and filling the survey forms. And they are community health workers and voluntary, you know, they are not like paid. Any work from the higher authority is simply assigned to them without even discussing with them in detail, not giving them that kind of any information. That is much worse in the rural areas. Like we have seen, they were posted for the gatekeeping at village borders, monitoring which vehicle is entering into the village. And these, this kind of role, like where there is a asymmetry of power which works. I just came to know, the one ASHA workers told us, like ANM, when they went for this vaccination, she was given an orange juice, whereas ASHA worker was not given orange juice after the vaccine was administered. So these are the small things, but these are very, very important when we talk about, you know, even in the context of, you know, their experience and whether we say it is a burdening, but in what context we are looking at it. The only couple of points I would like to mention here, because it's very important we need to bring back the discussion to the public health resources, how they were diverted to COVID-19, and how people from the marginalized and the vulnerable were left with no option. And ASHAs who are in close contact with the community were also helping the community members who needed that kind of additional health services, and because there was a lot of demand on them, not just for the COVID alone. And the government has directed the states to give rupees 1,000 per month as COVID incentive to all the ASHAs. But many ASHAs, they haven't received only they received only partial amount. And And of course, with this diversion, many activities were stalled in the public health movement. We all know what happened with the non-COVID. So their incentives for the non-COVID were lowered, and they were grappling with the financial costs. So that is also something we need to look into when they come from the lower socio-economic background. Coming back to the, I don't want to use the word burnout. I'm rather uncomfortable because I feel it's also something we need to locate it in the stress and the, which is also coming with, you know, the discrimination, and there is a physical and emotional violence, and there is a social apathy. I think unless we look into all these factors, we cannot just say, oh, they burn out, you know, kind of situation. Because unless we talk about how they have been discriminated, and I know like when they were not allowed, even within the family, you come from the COVID duty, and then you eat separately, you sleep separately, and then, you know, you receive the vaccination, so you are the more privileged in the family, and you are receiving, but we are not getting, you know, the vaccine within the family. So there are many, many dynamics. So it's not just the burnout, it is the stress, and also how it is affecting, you know, it is a kind of, I feel it is physical and emotional violence, and then lack of empathy. So this is something in the pandemic, in the lockdown period, and even now with the vaccine rollout, how the frontline workers are finding it difficult in reaching out to the communities and within their own lives, I think, which is very, very important when people are boycotting them or physical attacks. So lastly, one major issue was that the Ashas are doing community surveillance for COVID-19. But government was not at all concerned about their safety. They did not provide an adequate number of masks, for example. You know, we all know sanitizers, which we all have seen even now. One per the month they have given the mask, and then we know what quality of mask it could be. So the larger question of strengthening public health system, which has been weakened over the years, our reliance on the private health sector is so huge that during the pandemic, there was a huge setback and the private hospitals and clinics completely shut off. So we need to look into, you know, these factors when we are talking about the question which you have asked. Thank you.
Thank you so much, Sarojini. I know you had the discussions last week in Odisha, so they paint a very decent picture also, and a very holistic picture of community health workers' relationship with society, with family, among themselves also. I think one of the questions that we had was also on how these household dynamics impact their work, stress, and mental health, which you have addressed, I think, partially. Just moving on to Rajiv, I just have one question because you know, his context. I think the everyday resilience that Lucia talked about is something that clearly gels with the context that he comes from very well, and that you know, resilience is embedded in a lot of routine processes rather than a one-off sort of action. So I was thinking of now that people are asking, how do we use these conversations to raise important questions? And, you know, maybe he could talk a little bit about Kerala's capacity. I know that he talked a little bit before, but perhaps a little more on the kind of contextual capacities and the context that probably helped CHWs in his context. Just to give a positive note on how we can go ahead, what would be some of the next steps that we should do to achieve this kind of everyday systemic resilience. Thank you.
So I think before that, I think we need to take a step back. I think in the discussion, we need to separate what is a systemic problem with what happened during COVID. We know from the past pandemic, the first pandemic we saw was HIV, and pandemics have a habit of, or epidemics have a habit of increasing the fault lines that exist within the society, within the system. So most of what have been pointed out here are problems that exist within the system, which got accentuated during the pandemic. So the issues are broader than just relating it to resilience and pandemic. It's a systemic issue. So let's not forget that. The second part is the what does resilience consist of? Because when you have spare capacity, resilience becomes a lot easier. So spare capacity can also be generated when you're doing things little more than the bare essential. For example, in the transformed primary care system that Kerala has, it's a 1 doctor and 1 nurse. Kerala has 3 doctors and 4 nurses. Now, if you had to quarantine people during that period, this gives you a large depth in the system, which can be redeployed during this period to manage it. Now, how does a system that has not invested in that do something something like that? That's an issue that there's no point talking about it at this stage. For public health investments, that's a larger political question that has somehow not been addressed adequately. But there's a point that Avni made, and I don't think we have totally explored that, which is when as the epidemic was kind of petering out towards December, I called up some of my former colleagues on the field and asked them, "How do you feel? No? You've been working 7 days a week, and mind you, it's not community health workers alone who have been under pressure. Doctors, nurses, cleaners, everybody's been under pressure." So I said, like, "How are you guys coping?" He said, "Sir, we feeling like winners, and we have handled it, and that feeling of being a set of winners, and that if a system can generate that kind of feeling during a crisis, that we can come together and we can handle it. I think that is the biggest barrier that you can, or the biggest insurance that you have against future crisis. Can you empower your system? Can you empower your workers that when the push comes to a shove, they'll stand back and fight?" And the biggest takeaway for me from the way my colleagues responded to the to the pandemic was the fact that we stood up and fought. So one of the district officers told me, there were people we knew to be shirkers. We expect them to take leave and go. They didn't. They came every day, getting back to duty and getting back to work. There was an ASHA worker who said that, I know that I'm putting my family at risk. So the agreement I have with my family is that by the time I'm about to come home, they will keep all my clothes and everything outside. I'll take it, put my clothes for washing, have a bath, and then go back. But she wasn't complaining about it. She was seeing it as the fact that she was doing something that was important, and the fact that she was protecting her family. I think while we look at the burnout, the other challenges that people face, the self-actualization that many of the health workers, and I'm not talking about community health workers alone, was a positive lesson for all of us, and quite a humbling lesson also, that you expect people to be cold. They say, no, we're fighting back. And I think while we talk all about systems, the soft feeling of the team spirit, the high morale that I saw in display, and I'm sure this is true of the rest of many other parts of India also. While we talk about the negatives of this response, an important lesson for us is how the system stood and fought. It is like the army fighting a battle. Yes, there will be burnout, there will be challenges, but we will stand back and fight. And that to me was as I said, quite a humbling experience that I had when talking to my team. Thank you.
Thank you so much for that, Rajiv. I think that puts our everyday resilience in real perspective. So, we don't treat community health workers or any of our frontline workers as robots who go on doing mechanical work in the field, but people who take pride and joy in their own work, and it means a lot to them. Recognition, appreciation, all these things mean a lot to them, and that is what builds resilience in the health system. And we need to nurture this in community health workers. So thank you very much for summarizing this for us. We have a couple of questions which maybe there is one question on vaccination, and again there are great demands on frontline health workers during vaccination, and how can the system support them through that. And then there's one more question on how we can push governments to change with respect to health workers. And the third question is on mental health. So just pooling the mental health of community health workers. So just pooling these questions together, maybe I thought we could take a couple of take-home messages, maybe 1 minute from each of you, and then we can close this session. So this time I would start with Rajiv and then move on the line. Just one message sort of stemming around these questions. Thank you.
Let me respond to that question on the vaccination. It's quite important. We know that at this point, we are focusing on the people aged above 60. So if you've done your background work properly, you will have the list of people who are at risk from your reverse quarantine database. If you have that database, it will be very important, not only for frontline health workers, but the whole system to cover each of them and ensure that they get vaccinated. And that's going to be very important for us to work on this. On the situation with regard to community health workers, it's a lot more complex than I can answer within a minute. It has got lots of complicated issues, but the important thing is what is important for the government. No? I mean, like, is public health important? Once the answer is yes, then the question would be very different from what we are seeing now. I'll stop there.
Thanks, Rajiv. Is there like one last take-home message for anyone that you would like to leave us with? Or
this is not related to this, but remember, we have been ignoring the government health systems, and during this time, it is a government health system that has come in handy. And the important thing that all of us outside government can acknowledge is the fact that this system that we've been abusing for so long is the one that stood and fought for us. I hope that message is something that, including community health workers, we can start treating them with respect, because they were the only ones who were there when the chips were down. So that would be my plea to the people who are listening to this.
Thank you. I truly appreciate that last sentence. Thank you again. Maybe we'll move on to Avni. I think we the same 2-3 questions is what we have. I don't see anything new. One is on vaccination drives, if you have anything from your study which can impact it, but also perhaps how do we go about building resilience at the front line, and if you have any take-home messages for the audience. Thanks.
I think one point that someone in the audience also said, that building resilience is not going to be a one-time exercise. And I think that, as Rajiv said, I think one of the positives of the pandemic was that it brought a face to the community health workers, which have been neglected, and they didn't neglect us and their role, even though they have been neglected for many years. So I guess one positive coming out of this is that it's brought them back into the conversation, and I'm hoping that, so that's my takeaway message. Completely agree with what Rajiv said. I think just a couple of points in terms of positives, and again, it's good to end on a positive note. I think one of the things that was surprising but encouraging for us in our study was that only 11% of frontline workers reported facing challenges with support and supervision. And I think that it links back to Lucy's point of the context matters. For many years, we've always seen this role of the last mile as one that needs to be monitored, that needs to be supervised, but this concept of support is often missing. And we've seen this across sectors, so it's not something that's new for the health sector. And what we saw was like support being received was such an important motivating factor. So some of the supervisors were appreciated for offering flexibility in terms of when you can send reports, organizing refresher trainings if people needed it, reassigning work areas so that travel time could be less, escalating and resolving complaints faster. And these were done at this time, but I'm curious to see how one can actually sustain that and build that into the system going forward as well. And linked to that, of course, is the contextual capacities. And I think that's really important. Where do different actors fit in the larger context? Because there are often feelings of helplessness that are beyond your control. The fact that masks didn't come, the fact that ration sometimes didn't come, but then the community was asking for it. But you were in some ways didn't have the resources in terms of the ability, the authority to actually act on it as well. So I'm looking forward to actually getting the system to think about these contextual capacities as well, along with the two other capacities of behavioral and cognitive that Lucy mentioned.
Thanks so much, Avni. That was, I think, a fantastic take-home message for us. I think we will move on to Sarojini in the interest of time. And Sarojini, the same thing. I think there's a question on mental health and stress among health workers, which you had partially addressed. Maybe you'd like to take that. And maybe anything that people said about the vaccine, and one last take-home message. Thanks so much.
Add to what Rajiv just said, like, I think it's very important when we're talking about because one was looking at the vaccine rollout now, and then bringing the community experiences to the policy. And some of the things which we try to highlight is the lack of full information to the community health workers about the vaccine rollout. It may not be Kerala everywhere. Like if you see the back beyond places of Uttar Pradesh and Bihar, it's a very different situation. So we need to also contextualize when we are talking about the strategies to, whether it is vaccine rollout, or we need to go much beyond, because we need to have there is no transparency, definitely, which we are all talking about. Of course, accountability has come up. And also, like, the many were concerned, like, if there is any adverse event, where should we go? Not like everybody was, thoroughly trained on the COVID, and then this particular DIO, you have to go, and all that information gap is very much there. And nobody is saying that you shouldn't take vaccine. I think we are all saying like vaccination should be given. Nobody is saying, but it should be given with full informed information. And also we need to talk about the accountability, and also where they should go if there is any adverse event following immunization. If you provide that kind of services, even the community health worker will feel confident to mobilize the community, which will happen very soon. Not only them, even others. I think that is what we are also demanding from the various networks. So that is something related to the vaccine. But when it comes to the grievance redressal, I was just giving an example, positive example of the Chhattisgarh, like when Mahila Adhikar Samiti is giving that kind of support to the team. It's not coming from the state, but it is coming from the communities. I think that should also be strengthened. The community processes, how they will be supporting, the work. I think that should also be documented along with the other larger factors, which are very, very, challenging and then very difficult to influence at times at the policy level, but at the community level, we have a role to play too. Yeah, thank you.
Thank you. Unfortunately, I have to stop here looking at the time, but I thought this was an amazing discussion. So I would quickly thank the panelists. Thank you so much for pointing out some of the basic, first starting with Lucy, discussing some of the basic concepts, and Sarojini, Avni, and Rajiv for bringing out some of the deeper challenges in the health system in India, and also some of our strengths that we have. I think we've all agreed that we need to make some really hard changes with respect to the infrastructure and other things that community health workers needed. But also we all spoke about a lot of softer issues, appreciation, respect, and motivation, support to community health workers, and how we deal with all this. So I hope in our way forward we can include all this. Thank you very much again for being a great audience, to engaging with all these questions questions so well, and I thought it was a fantastic discussion. So I'm going to hand it over to Deepika to quickly make some last minute announcements and a vote of thanks to all of you. From my side, I exit. Thank you very much again. Bye.
Thank you so much, Sudha, for wonderfully moderating this session. And on behalf of the OPM WGHI team, I would like to heartily thank all our speakers and participants for this truly engaging discussion and sharing their reflections from their specific context, and also help us like sort of raising some of the very critical questions while the reflections were on what could be improved and how we go ahead from here. But there were also some positive reflections and the positive adaptations, and how do we sustain them as we move towards building the health system resilience in the future and prepare for addressing the future emergencies like this. So taking the conversation forward, the community of practice named CoreNet, of which OPM is also a member, would be hosting a 4-day conference in the month of April. And just to share quickly about the COP, CoreNet COVID Research Network, it's an effort to build community of practice, to foster exchange and collaboration among research organizations during the COVID pandemic in India. And it has 60 plus member organizations who are working across 23 states and union territories, and has nearly 80 plus research projects on the web platform. The CoreNet Secretariat is anchored by Quicksand with the support from the Bill and Melinda Gates Foundation. The conference would cover a wide range of themes, including resilient health system, nutrition and food security, gendered economic impacts, economic vulnerabilities, data system, adolescent health, etc. The event intend to showcase the research evidence that has been generated by the network and its members so far, and also focus on collectively reflecting on the learnings to inform the future responses for research as well as policy. It's a public event with participants from research organizations, government, program officers, donor agencies, and policymakers. The registration link for the event is also posted in the chat box, and we look forward to having you all join us, participate, and continue engaging through these sessions and events. And for any queries or doubts, you could follow us on the CoreNet website given on the screen, and also the email ID and Twitter handle for more updates. So with this quick announcement, I would like to thank you once again for staying on with us and engaging in this wonderful discussion. And we look forward to hearing your thoughts through so many other channels. Thank you so much, and have a nice day ahead.
Thank you. Thank you all.
Thank you.
Thank you.
Thank
Thanks
you.
a lot.
To everyone.